In this voiceover, we are more going to cover the different warning signs of cancer, so different signs and symptoms, different studies that are used for diagnosis, and different types of treatment, which include both medical and surgical interventions. So, this acronym that you see before you, CAUTION, is a good thing to remember with regards to signs and symptoms of cancer. This is an acronym that is commonly taught to patients who go to see their primary care provider. I'd really encourage you to know this acronym for the exam as well, because there could be some questions on this. Because of this acronym, it helps for patients to obtain preventative care in order to aid in early diagnosis and treatment of cancer. So, C for change in bowel and bladder habits, a sore that doesn't heal, unusual bleeding discharge, thickening of breast tissue or lumps, indigestion or dysphagia, obvious changes in warts or moles, and a nagging cough or hoarseness. So, diagnosis, I will tell you the best answer for the only true definitive diagnosis for cancer is always going to be through biopsy. There's many different ways to obtain a biopsy, but this is the only true definitive way to obtain diagnosis for cancer. So that could be a test question. So if you do obtain biopsy, remember the different ways that you obtain biopsy could have different complications related to the type of procedure. Such as a bone marrow biopsy, you could have issues related to bleeding. Kidney biopsies that we've talked about before. Like, it's good to know what types of complications could be related to invasive procedures that are performed. There could also be certain types of labs that can help with diagnosis, but it doesn't mean a true cancer type of diagnosis. So your CBC, so especially like white blood cells, red blood cells, any abnormalities in those, you can often help to find a diagnosis for like leukemia or lymphomas. An increased serum calcium is incredibly important because that can also determine if you have potential bone metastasis because your calcium is being leached out of the bones. There's certain tumor markers or genetic markers you can measure, which could help determine if you're at risk for a certain cancer or have a certain cancer. Prostate-specific antigen, which is your PSA. LFTs, which are liver function tests. And your CEA. What's important about the CEA, which is a cancer enzyme, is it can be increased if you have somebody who smokes. So it can't be a really good definitive diagnostic tool. But it can be very significant with regards to cancer. You would need other information such as imaging, biopsy, etc. to determine. So it's just kind of you need baseline information. So these are different types of diagnostic studies besides labs that you could obtain. So like a cytology would be like a pap smear to determine for ovarian cancer. Again, endoscopy, ultrasound, mammogram, etc. can all be good diagnostic tools to determine cancer. Again, biopsy is the number one indicator for diagnosis of cancer. So you can see there's some cool pictures here. You can see the cancer. It's an oligodendroglioma. So arising from the brain, you can see that huge tumor that's right there. You can see small cell cancer of the lung. So that's from just an x-ray in the lung. And you can see through an endoscopy or colonoscopy in that bottom right corner a gastric carcinoma that's growing there. So pretty cool imaging studies there. So again, biopsy, the only true diagnostic tool for cancer. There's several different methods to obtain biopsies. Again, they could have an open surgical case where they just go in, do an open abdominal to just see extent of cancer and to get biopsy of the tissue. So this can occur also for lung, GI type of tumors, ovarian tumors, etc. You can also find localized types of biopsy, such as skin. So a lot of times they'll do like a shave of the skin site or like a punch biopsy of the skin to determine types of skin cancer and how extensive the spread is. It's the same with breast. If there's a lump of tissue, they could do a punch biopsy or a liver. You could also do bone marrow aspiration, which is where they take an extremely long needle to insert into the bone marrow to aspirate some of that fluid to be able to determine for biopsy. In endoscopy and colonoscopy, they can go in and grab some of the tissue and be able to cauterize it afterwards to be able to obtain biopsy as well. So it's good to know there's different methods for obtaining tissue samples. So I'm going to talk a little bit about medical management of cancer. Many of you may be familiar with the different types of treatments that could occur, or commonly what they use for treatment for cancer. So the big thing, you often will see surgical techniques. So an example is my grandma last year was diagnosed with ovarian cancer. Because of her age and her risk factors, she couldn't receive treatment such as chemotherapy or radiation therapy, but she also needed a biopsy of the site. So they had to go in and do open abdominal surgery to do a hysterectomy, oophorectomy on her to try to remove the cancer, determine extent of the cancer spread, but also to obtain a biopsy. So surgical technique can be really important, not only for diagnostic reasons, so getting a biopsy, for curing and controlling the cancer, which in her case, they got all of her cancer. It could also be used for prevention. So for someone with breast cancer who has a BRCA1 gene or the BRCA1 gene, preventative technique could be a double mastectomy, with also a removal of the lymph nodes to help prevent cancer from occurring. You could also see supportive or palliative reasons, so maybe resecting a tumor to help make their life just a little bit better. Also for rehabilitative reasons. That little box you see on the right side of the screen actually pertains to radiation therapy. I don't know how it ended up on this slide, but it has to do more with another type of medical management technique. It can be used for curing and controlling a type of cancer, for supportive or palliative reasons, or for rehabilitative as well. So just know that these different types of management techniques all have certain goals in mind. So with radiation therapy, the whole purpose is to use ionizing radiation beams or discrete gamma ray sources to treat the cancer. So essentially, it destroys cancer cells and has minimal damaging effects on surrounding normal cells. So the area that it's targeting, that's where it's going to try to destroy the cancer cells. So again, it can be curative. It can cure the cancer. That may be the only treatment they need. It can be palliative, so it can help keep the tumor spread from growing. Or it can help, again, control cancer metastasis. So keeping that tumor spread from growing to keep them comfortable. Unfortunately, with radiation therapy, there are many different side effects and many different nursing interventions and cares that we need to know. So with radiation therapy, again, the advantage is it targets the location that the radiation is aimed at. So you don't have full systemic issues that you'd commonly see with a treatment such as chemotherapy, which we will talk about. It can destroy or shrink the tumor completely, so this could be the only therapy that is needed. And again, for inoperable cares such as like brain or bone mets, etc., it can be palliative treatment to keep it from spreading and to reduce the amount of side effects from the cancer. So, huge issues that can occur though with radiation can be radiation burns. So you often have patients who have to have specific skincare precautions because of burns. It can make them very tired and wiped out, especially after treatment and after a time period afterwards. Increased nausea, vomiting issues. You could also get secondary cancers from radiation treatment. So when we were talking about environmental side effects with causes to cancer, radiation therapy can actually cause a different type of cancer. So it could actually cause a leukemia or a lymphoma if you're just treating like a certain type like breast cancer. So you could also have issues with neutropenia or thrombocytopenia from radiation therapy. So, as in the previous slide, there's two different types of radiation therapy. There's teletherapy, which is radiation that comes directly from an outside source. So for this patient, they don't have any internal sources of radiation that they're carrying around with them. So the specific precautions just deal with the treatment time period. So the person who's administering the radiation therapy, plus the cares that you'd have to do with regards to skincare, etc. So for a patient with internal brachytherapy, there's a radiation source that has to be a direct continuing source at that site. So this could be like a patient with ovarian cancer or uterine cancer who has seeds that are placed in the vagina to help with radiation therapy control. Or this may be a patient who has prostate cancer who has radiation seeds inserted near the prostate to help decrease the amount of cancer. So there's quite a few special considerations, but there's very high dose that's being directed towards the tumor and a limited dose to the surrounding normal tissues. That's the whole purpose of radiation therapy. So with regards to time limits, this is a patient that you're not going to spend a lot of time caring for. These patients will have interventions that are directly used to help limit your time with them. So big time precautions is you need to limit your time to 30 minutes in an 8-hour shift with this patient. So you're going to wear something like that dosimeter that's on the bottom left picture to help measure the amount of exposure you have to radiation therapy. Typically hospitals, it's not going to tell you time limits, but hospitals will measure it at the end of the year to determine how much radiation exposure you had. You'll often see x-ray techs wearing dosimeters as well, just because they're exposed to radiation quite a bit. The time limits mean that you really need to cluster your cares for these patients. So these are not patients that you're going to chart in the room with. These are patients that, you're going to go in, do a quick head-to-toe assessment. They will have Foley catheters inserted, so they're not getting up to go to the bathroom. They will be given meds to constipate them, so they're not straining, because you don't want them to strain. Their meals, like you'll just bring them in, and they have to be able to eat by themselves. You can't feed them, and they should be able to turn themselves, but though they have to stay in one position for a while. So these are patients you're really just going to go in, do your quick assessment, check their Foley catheter, check on them, make sure their pain's under control, and then leave them alone. And so these patients are educated to know that they're not going to see a lot of nursing presence in that room. This also means like your CNA is not going to be going in there. It's most likely going to be you delivering all the primary care. These patients also will not be receiving, baths at this time. So other precautions should be, this is not a patient you're going to have several days in a row. You're only going to care for them for one day, and then somebody else has to switch off. There's particular types of shields that will be located in the room. So you can wear a lead apron to help decrease the amount of exposure if it's available. But you can see in that middle picture, there's that little shield there that you would use. So when you're doing your assessment, you would just roll that in front of you and kind of roll it around the room with you. It's good to know if you're trying to conceive or you're pregnant, you're not going to be caring for this patient. And children under 18 are not going to be allowed to see these patients as well, just because the amount of changes that occur in their normal cells. It's good to know as well that you should attempt to remain at least 20 feet or more away from your client. It's good that you use that middle shield as well to help with that in that case. So if you have issues where, the radiation seeds fall out, there should be a lead bucket in there and tongs to be able to grab those and put them in there. It's also good to know that your linens or anything that you use to change those beds and your garbage are all kept in the room until that patient discharges, where you can go through it to make sure there's no sources of radiation that were thrown out in the linens or in the garbage. The big thing is if those radiation seeds fall out, you will also be notifying your physician. You have to place them in that lead bucket, though, first. So this is a list of the different types of side effects that you will find with radiation therapy treatment. It's common most likely with your teletherapy. The biggest ones you'll see would be alopecia, which is typically localized to the site, but can often be permanent because you're altering those cells. So this differs from use of chemotherapy that we'll talk about later, because chemotherapy, it can be more systemic type of hair loss, but it will grow back. It might grow back altered, but it'll grow back. So alopecia with radiation therapy, it's localized, but it's permanent. You'll have issues with nausea, vomiting, fatigue. You could have rashes, burns, edema, any issues with your skin. You will notice you'll have neutropenia or thrombocytopenia with radiation therapy, which is commonly seen with chemotherapy as well. You may have issues with difficulties in swallowing, which is like that dysphagia because of changes in that skin tissue, especially depending if they're where that radiation therapy is being targeted, or esophagitis, which is some inflammation in the esophagus. So you can imagine how this would alter nutrition, or how altered taste changes could go along with this. So altered taste changes, you will find patients will have issues eating with metal silverware. It'll cause a weird taste in their mouth. They'll have issues, like things just won't taste the same. So spicy food, they'd have issues versus sour. You can also have cancer, again, a different type of cancer reoccurring because of radiation therapy, because again, it's that environmental factor. So you might have, radiation therapy again for like breast cancer or, a glioblastoma and end up with like a leukemia or lymphoma later on in life. So the big assessments prior to radiation therapy and post-radiation therapy is, does the patient know what they're undergoing? So part of this is the physician's job to educate them that this is what radiation therapy entails. These are the risks and the benefits. So that's part of the oncologist or, your radiation oncologist job. But it's also our job to support that education as well. Are these patients able to reach all of their appointments? It's good to assess that. Do they have somebody to drive them there? They may need somebody to drive them home because they will be tired. These patients need to also be able to lay flat on a table, need to move or tolerate long treatment positions. You also need to know you need good head to toe assessments, good skin assessment of their skin condition, their energy level, how well are they able to perform ADLs. You need to evaluate their nutrition intake. So are they taking in fluids? If they're having difficulty swallowing, do we need to change the types of textures of foods that they're eating? Are they getting enough calories? Do they need a supplement? Oxygenation actually helps increase the uptake of radiation therapy. So it's good that they have appropriate oxygenation therapy or their SATs are good before they undergo radiation therapy. So it's also good to know how to treat skin for these patients undergoing radiation therapy. So you want to make sure, if you can see in the right hand corner, they have a mark where they can target that specific tumor site. You want to make sure that this doesn't get washed away. So you want to educate the patients not to scrub at it, not to wash it away. It's often called a tattoo. These patients need to be educated not to be using their normal deodorants, soaps, lotions, or perfumes unless it's directly prescribed by the provider, or the provider can make certain recommendations regarding these types of things. They shouldn't be shaving an area with a razor. So, faces, if they have a hairy chest and they want to shave it to help with that, or their legs, they need to be encouraged to avoid doing that because you're just opening that area for infection, especially when already immunosuppressed, and causing more irritation. They shouldn't be applying any hot packs or cold packs on areas that they have pain because it's going to increase their skin sensitivity is increased and they're going to have issues with that. And they need to be wearing loose, cotton, flowy clothing that doesn't have binders or elastic, so nothing really tight, especially around that skin site because you don't want to irritate that. So you can have issues with edema. It could become weepy, excoriated, their skin can look tanned, etc. So it's good to give them appropriate education as to what could happen after radiation therapy. You also need to assess, because fatigue is a big sign and symptom, how do they perform their ADLs at home? Do they have somebody to help them? Are they ensuring that they receive adequate rest? So chemotherapy, and this is an area that I worked with quite a bit when I worked on a inpatient floor, was administering chemotherapy, especially to patients who were sicker than they normally would or needed to receive chemotherapy over a certain period of time. So it's essentially the treatment of cancer with chemical agents that targets all rapidly growing cells. So again, how this differentiates from radiation therapy is radiation therapy is more localized versus chemotherapy is more systemic. So it's used as a curative form of treatment. So undergoing chemotherapy can cure the cancer. It could be palliative, so to prevent cancer growth or to help control symptoms, or it's used with radiation therapy. So you can have chemotherapy, radiation therapy, and surgical therapy as all for treatments for one type of cancer. So this is where the classification system comes in, because the different types of classifications determine the amount of chemotherapy we use, or the types of chemotherapy we use. So it's important to know there's specific classifications of chemotherapy that you use, just like you have specific classifications of drug therapy. So you could have, anti-metabolites, anti-tumor antibiotics, antimitotics, alkylating agents. So not all of these chemotherapeutic agents need specific chemo precautions, but it's good to exercise chemo precautions on all of them just to be safe. So all of this essentially interrupts cell growth, which all those rapidly dividing cells are usually affected, and that's what's causing your side effects. So if you think all the rapidly growing cells are skin, your hair, your intestinal tissues, so in your intestines, your esophagus, your mouth, any reproductive systems, blood forming cells, all of those get affected, which is where you get your side effects. So common side effects that you will see are your stomatitis, which is you will have mouth sores, because again, it's a rapidly dividing cell. You'll have issues with nausea, vomiting, alopecia, kind of like we described with radiation therapy, pancytopenia, which means deficiency of all the red blood cells, white blood cells, platelets, etc. And then again, with the stomatitis, you could have dysphagia, or because you have intestinal cells affected, you'll have issues with diarrhea and constipation. So an important word to know is nadir. That nadir is the lowest level of bone marrow suppression and white blood cell activity. So on the floor, we would know 7 to 10 days after their first treatment of chemotherapy, a client would be entering their nadir. So we would expect that they would be immunosuppressed and put them in appropriate neutropenic precautions regarding this, and be monitoring their blood tests, so their CBC, which includes their red blood cells, white blood cells, platelet count, etc. So we would be monitoring for this. So it's important to know what nadir is. That could be a test question. So chemotherapy is often infused via several different ports. So I kind of put some pictures of different types of sites. But you could see different types of catheters. I'm sure some of you have seen a portacath this semester, or seen a portacath be accessed in the ER. I know a couple of my clinical students have. So that's that picture that's kind of in the middle of a portacath, and that's a surgically implanted catheter site. What's nice about a portacath is these patients, when they're deaccessed, can go swimming or do whatever they need to do and shower and not have to cover that site up unless it was accessed. You can see on the left there's a Hickman catheter. These are seen commonly in patients who are going to have long-term treatment. So leukemia patients, lymphoma patients would have a Hickman catheter inserted. And keep in mind that that tip of that catheter is still leading directly to the heart. So you have to be very careful. So these are both considered certain types of central lines. You may see intraventricular, which is that Ommaya reservoir up there in the corner. So this could be for certain types of glioblastomas or lymphomas. You could see with brain mets, essentially, you will see injections of chemotherapy in an Ommaya port reservoir. And this type of injection is commonly done by the physician. That external infusion pump could be for patients who go home with chemotherapy infusing over a certain period of time. So it's kind of cool to see one of those or have to set up one of those. So sometimes we'll use like methotrexate in there, but it infuses at a slower rate. So essentially, you'll have your central venous catheters, which is like your Hickman, your portacath, like a PICC line. You'll see PICC lines used as well. You'll see, again, those external pumps being used, the implantable pumps, which are in the brain. So your intrathecal is where they can infuse chemotherapy in the spine. It essentially helps cross the blood-brain barrier. So again, you can use intrathecal. The intraventricular, again, is that Ommaya reservoir. Intraperitoneal, we can kind of talk about intraperitoneal therapy, but essentially they instill chemotherapy in the abdomen. This is my least favorite type of chemotherapy to administer. It's very time consuming. And intravesicular essentially is irrigation of the urinary bladder with a certain type of chemotherapy, and they use a 3-way Foley catheter, which you guys learned about in NU 313, to try to instill chemotherapy. So this would be sometimes somebody with bladder cancer. They would instill an inactive form of TB bacteria to help trigger the immune system for treatment, or mitomycin, etc. They would instill the chemo essentially into the urinary bladder. So big complications that you always have to monitor for a patient with chemotherapy is extravasation. So those are some pretty gnarly looking pictures of extravasation with infusion. These can high risk of occurring, especially with particular types of chemotherapy. So it's always good to monitor your infusion site, and this is why peripheral lines aren't used quite as much and why we use central lines. a little bit more, but it can occur if that central line is dislodged. So it's good to monitor with certain types of chemotherapies. So treatment for someone with extravasation, you would need to make sure that you stop the chemotherapy. It depends on the type of chemotherapy and hospital policy, but sometimes they'll have you try to draw out the rest of that chemo. You would want to leave the line in because there's oftentimes an antidote that you could provide in that line, so you'd want to leave that peripheral line in unless the physician indicates you need to pull it out. You would make sure you're obviously reporting this immediately to the physician, to determine the type of treatment that you would need for somebody who's experiencing this. Pretty much just don't apply pressure, don't flush after it with saline, etc.